Good evening, all. Welcome to this new session of Pediatric Spotters. I was busy with the practicals of PGs and their exams, and even theory paper evaluation, and even attending the conference. So I was not able to upload the video for the past 3 weeks. So coming to the Pediatric Spotters, first we will see here. You can see this is a neonate where you can see there is a depressed skull fracture. This is typically called as ping pong fracture, where there will be depression. This is nothing but the depressed fracture in case of neonates, and sometimes in these cases the fracture line could not be visualized clearly. So depressed skull fractures in case of neonates is nothing but ping pong fracture. This is an infant where you can see there is a depressed skull fracture and the fracture line is clearly seen. So this is a case of depressed skull fracture in an infant. And here you can see this is a diastatic skull fracture. These diastatic skull fractures occurs along the sutures with sutural widening and separation. And here you can see in the same case there is gliosis or encephalomalacia which is extending into the diastatic skull fracture, which is nothing but leptomeningeal cyst. So this is a case of diastatic skull fracture with leptomeningeal cyst. Next, this was a case of a child presenting with intellectual disability and even delayed milestones. Here you can see there is macrocephaly. Here there is J-shaped cella, and also you can see there is proximal pointing of metacarpals. And here you can see there is widening of the anterior ribs, nothing but oar-shaped ribs or paddle ribs, and even clavicles. And here you can see there is flattening of the vertebra, and typically you can see there is anterior inferior beaking of the vertebra. So there is flattening of the vertebra with anterior inferior beaking of the vertebra, which may present with kyphosis or gibbous deformity. So anterior inferior beaking of vertebra is classically seen in hurlers, whereas central anterior beaking, that is middle one third of the beaking, is nothing but seen in case of Marcus. So remember, middle one third for Marcus, M for M, middle one third for Marcus, whereas anterior inferior beaking in case of Hurler syndromes, and sometimes it can be also seen in achondroplasia, congenital hypothyroidism, other cases. And also in the Hurler syndrome, classically in the brain, you can see there will be ventriculomegaly, diffuse white matter changes, even hydrocephalus, and the classically is multiple dilated perivascular spaces or Wittchow-Rabin spaces. This is classically in case of brain in case of Hurler syndrome. So macrocephaly with J-shaped cella, proximal point of metacarpals or bullet-shaped metacarpals, even anterior inferior beaking of the vertebra classically are seen in Hurler syndrome or MPS type 1, that is Mucopolysaccharidoses type 1. Next, this is a other case where you can see this is a premature baby which presented with abdominal distension and even vomitings. Here you can see these are the gas distended bowel loops, and also you can see there is free air noted within the bowel wall. So there is free air noted within the bowel wall, and also you can see here you can see there is free air along the portal vein. So there is free air branching pattern seen along the liver in both lobes of liver. So this was a case of necrotizing enterocolitis. Along with there is portal vein gas. So remember, necrotizing enterocolitis can also present with portal vein gas as complication. Here you can see there is free air noted within the abdomen, and even there is a Wriggler sign, that is free air noted both inside and outside the abdominal wall. So the free air lining the abdominal wall is depicted as Wriggler sign. So this is pneumoperitoneum. Here also you can see there is pneumoperitoneum in decubitus view. This is a case of pneumopericardium where there is free air within the pericardium. So this is pneumopericardium, and here you can see this is significant pneumomediastinum, with splaying and displacement of the thymus gland, both lobes of thymus gland, which is nothing but depicted as Spinnaker sail sign. So remember, I have shown you all the NEMOs, that is free airs. So one is nothing but necrotizing enterocolitis with portal vein gas, second one is significant pneumoperitoneum, third is pneumopericardium, and this one is pneumomediastinum. And these are the common cases which will be asked in spotters and even FRS. Here you can see this is a child presented with respiratory distress. Here there is defect noted in the diaphragm, and there are herniation of the bowel loops into the hemithorax with displacement of the mediastinum. So this is a classical case of congenital diaphragmatic hernia. So the common differentials are nothing but CLE, that is CLO, that is congenital lobar overinflation, and this is CPAM, that is congenital pulmonary adenomatoid malformation. Here you can see there will be hyperinflated air-filled space filling the left lung, mostly in the upper and middle lobes, with few thin septations, and there will be shift of mediastinum. So this is nothing but CLO, that is congenital lobar overinflation, which was previously called congenital lobar emphysema. And here you can see there is a large cystic lesion filling wall of the right hemithorax. There are multiple cystic foci also noted within the lesion with thick septations. So this is nothing but case of congenital pulmonary adenomatoid malformation. So CDH, CLO and CPAM form good differential diagnosis and commonly asked in spotters and even FRS and even in the theory. Next, this one you can see there is a child which is presenting with bulging abdomen, which is nothing but protuberant abdomen. So whole of the abdomen is protuberant and bulging. This will be classically seen in case of Prune belly syndrome, where there will be defective anterabdominal wall and underdevelopment, and there will be bilateral VUR or pelvic axial or pelviureteric dilatation and even ureteral dilatation along with undescended testes. This triad form the Prune belly syndrome or Eagle-Barrett syndrome. Here you can see there are multiple bowel loops noted on the right side of the abdomen through defect noted in the right side of the abdomen, which is classically seen in gastroschisis. And here you can see there is a large swelling noted in the anterabdominal wall at the level of umbilicus. There is herniation of the bowel loops and even liver. So this is a case of Omphalocele. So remember, Prune belly syndrome, gastroschisis and Omphalocele form common differential diagnosis. And this is a classical cases of Rickets and Scurvy, which are commonly asked in theory and viva. Here you can see this is playing of the metaphysis, nothing but playing of the metaphysis, which is nothing but metaphyseal widening at the end of the bones, and this is nothing but cupping of the metaphysis. Here you can see this is the deep cupping or concavity of the metaphysis, which is called as cupping. And here you can see there is irregular metaphyseal margins, which is nothing but fraying of the metaphysis. So irregular metaphyseal margin is nothing but fraying. Deep or concave margins of the metaphysis is cupping, and nothing but widening at the level of bone ends is nothing but splaying. So splaying, cupping and fraying form the classical features in Rickets. And here you can see these are multiple dilated widened ends of the ribs with beading, which is classically nothing but called as rachitic rosary. So all these are classically seen in Rickets. And the counterpart is Scurvy, where you can see there is Pelkan spurs. You can see these are the metaphyseal spurs, Pelkan spurs. And this is the radiopaque shadow adjacent to the epiphysis, which is nothing but Wimberger ring. And this is dense zone of provisional calcification called as white line of Frenkel. And below the dense zone of calcification, there will be lucent metaphyseal zone, which is nothing but scorbutic zone, which is called as Trummerfeld zone. So Pelkan spurs, Wimberger ring, white line of Frenkel and Trummerfeld zones are classically seen in Scurvy. Along with, you can see these are the subperiosteal hemorrhages, which are also seen in Scurvy. So these two are commonly asked in theory and also in viva. Here in this case, you can see there is diffuse swelling in the scalp, and also there is a diffuse swelling in the scalp bilaterally. This is VRT reconstruction showing cephalohematoma. Cephalohematoma is nothing but traumatic subperiosteal hematomas which are limited between the periosteum and the bone. So this subperiosteal, because they are limited between the periosteum and the bone, these subperiosteal hematomas cannot cross the sutural lines. So cephalohematomas cannot cross the sutural lines, whereas here you can see there is diffuse scalp swelling which is crossing the sutural lines, which is nothing but serosanguous or subcutaneous fluid collection external to the Galea pneuretica. So this is Galea pneuretica, and superficially you can see this is the serosanguous collection, so it can cross the sutural lines. Cephalohematoma cannot cross the sutural lines, whereas Caput succedaneum crosses the sutural lines. And one of the other common DD is subdural hemorrhages. And here you can see this is the commonly asked in theory and viva. Here you can see there are diffuse reticular opacities which are confluent to form the whiteout lungs with air bronchograms. So this is hyaline membrane disease with whiteout lungs. This is bronchopulmonary dysplasia, where you can see multiple reticular markings interspersed with lucent areas of air, and even there may be cardiomegaly with bronchial wall thickening. So this is severe form of respiratory distress syndrome depicted as bronchopulmonary dysplasia. And after treatment with positive pressure ventilation, there will be abnormal gas collection along the pulmonary lymphatics and even the pulmonary interstitium and lymphatics, which is seen as thin linear lucent areas which are radiating from the hilum. And even you can see there is minimal pneumothorax. So this is pulmonary interstitial emphysema seen in case of barotrauma or positive pressure ventilation. And sometimes this pulmonary interstitial emphysema is significant, can present with massive pneumothorax. So these four form the spectrum for neonatal respiratory distress syndrome. And other DD for these two, that is hyaline membrane disease and bronchopulmonary dysplasia, is transectocopy of newborn. So these are the few pediatric spotters. I will continue these pediatric spotters in the next session. Thank you all.